of prostate gland, fusion biopsy, and the focal treatments are emerging. Actually, multiparametric MRI and fusion biopsy are already the standards for today algorithm of the diagnosis of the prostate cancer, but the focal treatments are seriously emerging new therapies. We will talk about them at the end, but for now, we will start with the MRI and the fusion biopsies and how they made a huge paradigm shift in the diagnosis and management of the prostate cancer. Okay, I have no conflict of interest. Okay, when I personally started working on multiparametric MRI is 2012. Actually, 2012 is the first year when European Society of Urogenital Radiology, ESUR, first published their guideline on MRI examination of the prostate gland, and the first version of the PIRADS classification. This it's similar like in breast cancer we use BIRADS, in thyroid cancer we use TIRADS. Nowadays we started using also classification for liver cancer called LIRADS, L-I. But the first version of the PIRADS was published in this guideline. Actually, I was a radiology resident at that year, and I was very interested in prostate cancer diagnosis. At those years, we had only 1.5 Tesla MRI at our institution in the Istanbul University School of Medicine, and I was doing at that time. I was the first one who was started doing prostate MRIs with endorectal coils, because nowadays multiparametric MRI should be performed with 3 Tesla MRI devices. It's preferred first line, but also in new generation 1.5 Teslas we can also do for today. But those years 1.5 Teslas were not suitable, so we had to use endorectal coils, and it was really painful for the patients, to be honest. So I started doing that time these imagings in our university as a resident. I had no mentor for it. I started doing by myself. So our chief of the department sent me to this meeting in Dubrovnik, Croatia in 2012. So when first PIRADS was classified, I was actually part of it. And I went back and prepared this presentation. It is the image of the first slide of that presentation when I presented this PIRADS to my colleagues in Istanbul. So with the MRI technology, now we can easily and more visually define zones of the prostate radiologically. Okay, so now we have a zonal anatomy of the prostate with MRI. Before, with ultrasound, we didn't have that much resolution, that good resolution of the zones of prostate. But nowadays, we can do it with MRI. So to remember those years, I put these were endorectal coils that we were used for 1.5 Teslas. They were really painful. But now today we do prostate MRIs with 3 Tesla MRIs, and just with single abdomen coils, we can do imaging easily and comfortably for the patients. Look, this image is from my those years. This is 1.5 Tesla. This is endorectal coil. You see how big is it in the rectum of the patient, and the images were not so good as 3 Tesla images. But today, new generation 1.5 Teslas are not so bad. So in the new versions of PIRADS classification, we may use, but very experienced radiologists should perform these imagings with 1.5, with new generation 1.5. But preferably 3 Tesla is the first choice. So now we don't have a PIRADS version 1 that we have created in 2012. But today we use version 2.1. 2.1 PIRADS is more user-friendly. We diminished with throw out some useless criteria of the PIRATS classification, like MRI spectroscopy and so on. So today we use PIRATS classification version 2.1, mostly with the T2 imagings and diffusion imagings. And sometimes we put also dynamic contrast imagings. So with zonal anatomy, we have now different PIRATS for the peripheral zone lesions and for the transitional zone lesions. We use different PIRATS classifications from 1 to 5. Okay, it's very similar like in breast. 1 is totally normal, 2 is like totally benign lesion, 3 is mostly benign, 4 is very suspicious, 5 is almost sure that it is cancer. So I'm not going to talk to oncologists about the incidence and the prevalence of the prostate cancer. You know that how it's important for the male health and its place in modern oncologic approaches. But we have to understand a very important thing about prostate cancer. Prostate cancer is not always clinically significant, because we know that in the autopsy studies that many male people have a very low Gleason score cancers in their prostates during their lifetime, and it was not even diagnosed, and it did not even cause any symptoms. So we need to find out clinically significant prostate cancers. So we have very nice reviews and systematic reviews and the meta-analysis on this kind of studies. So our aim with this multiparametric MRI is to find out clinically significant cancer. So this is very important for us. So what urologists and oncologists are expecting from radiology in the diagnosis of the prostate cancer, also in the staging and follow-up. So first, we are aiming to localize the tumor first, because in previous years, when we had only ultrasound, transrectal ultrasound imaging for the prostate, we could not localize the tumors. Now with the MRI, we have ability to finally localize the tumor in which part of the prostate gland it is localized, because it is very important. We know that prostate gland is not so big as breast or other solid organs, but still localizing tumor is helping us to improve our treatment approach, our side effects, and effectivity of our treatments. Okay, so this after we localize these tumors, now we have an ability to make a target biopsy from these lesions. Because in previous years, when we had only ultrasound imaging in which we couldn't localize a tumor, we could not make any target biopsies. We were doing systematic biopsies, which about I will talk a little bit later. But now we have localization, target biopsy. We can use MRI or other radiological imagings for staging, as you all do routinely, and of course for follow-ups after the local treatment or after surgery or after the systemic treatments. So with the multiparametric MRI, we have better imaging of the zonal anatomy of prostate, better functional knowledge. We have a guide for biopsy, and we have really very high sensitivity and specificity. So what is multiparametric MRI? How it differs from other MR imagings? Actually, to be honest, there is no big difference from for example, upper abdomen dynamic contrast imaging of the liver, for example, right? So it is multiparametric MRI name is a little bit a fancy name for it, because all these sequences that we use for imaging are the same as we do in, for example, liver imaging, right? So no big difference from the liver imaging. Liver imaging MRI is also multiparametric, we can call it. But to to daily use. It is fancy, it's a nice name, so it's still being used like this. But some centers, for my center also, we use it as a prostate MRI. So we know that how prostate MRI should be done, so we can call it easily a standard prostate MRI. Okay, in T2 sequences, we need to see hypointensity. More dark image, it's more probably malignant. Okay, hypointense, this is one is also hypointense, this is almost black. So more hypo, it's more likely it's cancer. Diffusion imaging is very important in prostate cancer, like in majority of all other abdominal solid organ tumors we use. In diffusion imaging, what we are looking for? We are looking for diffusion restriction of the tissue. When there are too many cells, like in the tumor tissue, the interstitial spaces are very narrow and the water molecules are not easily diffusing into the cells. So this is what we call diffusion restriction. And in diffusion sequences, tumors which are restrict tumors, they should be lighting, and they should be bright. Also, we have to verify this diffusion brightness with the ADC. On the ADC part, it should be, what we call ADC mapping is the digital images that are created from the diffusion images to verify that that brightness on the diffusion is a real restriction of the tissue. So this part is also very important from the imaging perspective, because in this ADC data that we take from this diffusion image, it is quantitative data. So we can easily try to correlate it with the Gleason scores of the biopsy specimens after the biopsy. So the retrospective data that evaluated these quantitative ADC values with the Gleason scores of this patient showed us enormously important information that now we are finally have an ability to tell how aggressive the tumor is without a biopsy. Okay, so and we can do it quantitatively. So it's really important. And this Nature Scientific report in 2018 by the Japanese study showed us that this is very promising. So probably in future we will, with the very nice MRI image, we will probably even not have to do a biopsy of the prostate, probably. Yeah. So also in the multiparametric MRI, we have dynamic imagings, contrast enhancement, and the early contrast enhancement and the washout of the contrast in the dynamic image also shows us that it is probably suspicious, or it also increases the Pirate score of the lesion. So now we can, after we are able to localize the tumor, we have a chance to do a finally target biopsy, which we call fusion biopsy, because we do mostly our biopsies under the ultrasound guidance, but we don't see the images. We don't see the lesion on the ultrasound. We see a lesion on MRI. So we need to fuse these images with ultrasound image and with the MRI image, so we can see where the lesion is on the ultrasound. Okay, so now with this technology and with this new approach, we have a serious paradigm shift in the diagnosis of the prostate cancer. What we were doing before, we were doing prostate standard transrectal ultrasound biopsy of the prostate for almost every patient who had a raised PSA and also abnormal digital rectal examination, right? So let's assume that almost every patient with a high PSA over 10 probably, or over 8, sometimes even over 5, who had also a suspicious nodule on the digital rectal examination, were undergoing a standard prostate biopsy. And if we had a chance to diagnose a cancer on that biopsy examinations, we were going after for staging, and we were proceeding with the treatment, right? So, and this biopsy that we were doing before, like standard systematic biopsies, we know that almost 35 to 40% it had a false negative results. Okay, so almost every male patient with the high PSA were going through biopsy, and the biopsy which was 35 to 40% giving us a false negative results. So it was a huge problem actually. What we are doing now, today our algorithm works like this. We have a patient with the raised PSA. Elevated PSA, you know, that is not always an indicator of the cancer. It may be elevated in benign prostatic hyperplasia. It may be elevated in okay. It may be elevated in the prostatitis also. So we get a patient with the elevated PSA. We send them to MRI. We make our MRI scans and we evaluate. If we have suspicious lesions, if we don't have any suspicious lesions on the MRI, where the MRI is negative, it's like Pirates 1, Pirates 2, and Pirates 3, okay? Like 1, 2, 3. We don't do any biopsy for these patients. And these are almost 50 to 55% of the patients. Now we save almost 50% of our patients from the useless biopsies, okay? And we were not doing biopsy to all of them now. On the MRI, if we see a Pirates 4 or Pirates 5 lesions, we go to the target biopsy together with the systematic biopsy. I will explain you later that why I still practice like I do target biopsy and systematic biopsy together still. Positive MRI results now we do a target biopsy which has almost 97-98% sensitivity, okay, with the targeted lesion biopsy. Now we have more with less false negative results, almost 2-3% false negative results here. We have a real cancer diagnosis. We stage the patient and we send them to the treatment. So to remember what was systematic biopsy for the prostate before, it was like we don't see where the lesion is, and we are making a 12 needle biopsies from the different parts of the both left and right lobes of the prostate blindly, almost blindly. We didn't see where the lesion is, so we were doing just and with the bigger prostate tissues, it was harder to find target the lesion properly. So this is what we have told about, that especially on the anterior sides, when the lesions were on the anterior sides or on the very periphery of the prostate gland, it was really hard to shoot them on the systematic biopsies. Now we have a target biopsies, what we call fusion biopsies. So how do we do this fusion with ultrasound and MRI images? How we do their fusion? We have two ways to fuse these images. One is cognitive fusion biopsy. Cognitive fusion is done by very experienced radiologists who have the three-dimensional way of thinking, and when we see the lesion on MRI, we just cognitively create the image of the three-dimensional image of this prostate gland in our mind, and we so easily find that area on the ultrasound imaging lively when we are doing the biopsy. Okay, so the second version of the fusion technique is using special devices for this fusion for this fusion procedure. These are the very different brands, different technologies that are used to fuse MRI and the ultrasound imagings. And the third way is a little bit more difficult and uncomfortable for the patient and the doctor, is that doing a biopsy inside the MRI device with the special needles that are non-magnetic, okay? We call it inboard biopsy inside the MRI device. So it is really, I tried it in the first years, but it is really uncomfortable for both patients and the doctor. Excuse me. Okay. So what is cognitive biopsy? I have told you before. So in the cognitive way of doing three-dimensional fusion, radiologists should really have a mindset for three-dimensional analysis. So especially interventional radiologists, we are doing on a daily basis. We do different kinds of imagings for these patients, like MRI, ultrasound, angiography, fluoroscopy, and so on. All of these imagings are two-dimensional, but especially MRI and CT gives us an ability to understand this kind of different lesions, vascular or tumoral lesions, three-dimensionally. So when an interventional radiologist who is practicing interventions on daily basis, for an experienced interventionalist, it is really very easy thing to have a three-dimensional analysis capacity. Okay, I have told you before that zonal anatomy of the prostate is very important for us. So when we do this, when we know this classification of zones by heart, we can easily define where the lesion is technically with the name of the zone and the part of the zone where it's located. It may be apical part, it may be mid part, it may be mid-basal part, or the basal part of the prostate. It may be on the right or left, it may be anterior, posterior, it may be close to the transitional zone, or it may be inside the transitional zone. So this classification helps us to memorize the location in our mind. So for example, here we have a lesion on the MRI. This is T2. It's pretty dark. It's hypo-intense. So we know that it's very suspicious. Probably it is one of my patients, and probably it was malignant. I don't remember the biopsy result of this patient especially, but it is probably malignant. So we have a peripheral zone. This is the transitional zone, and this is the peripheral zone. So we have the lesion here. It is close to the apical part of the left peripheral zone. It is located posteriorly. So it is really very easy for me, for an interventional radiologist, to find it cognitively on the ultrasound imaging. So, and we sometimes when the prostate is very big, sometimes we use landmarks to remember where the lesion is. For example, here we have a lesion on the peripheral zone, and we have a very close cystic lesion which is located to this tumor. So sometimes we use this kind of landmarks. Okay. Some calcifications or other organs like urethra and the contours may be used in the beginning when the radiologist is training for the cognitive biopsy, fusion biopsy. You can use these landmarks. Okay, why I personally prefer to do cognitive biopsy? The most important thing, because I am really very busy. My daily schedule is very tough with different kinds of interventions, from angiography to cerebrovascular. Most of my practice is oncology. I'm more interventional oncologist than a general interventional radiologist, but majority of my time is passing in the angiography suite. So to do prostate biopsy, I have to go to the general operating room where the other surgeons also work. So for me, the main advantage of the cognitive fusion biopsy rather than you doing fusion with the devices is it's a time friendly. It's very fast for me because the other devices are really take very much time. Okay. And in the cognitive biopsy, it's also very cheap, because for other devices you have to buy the device. We have to bring an extra technician to use this device with you when you are sterile and so on. So the fast, cheap, and when in experienced hands, it is as good as any other kind of fusion technique. So, okay, like as I said, but for negative aspects, it is hard for the urologists to do biopsies, because like first years when the prostate biopsy, like standard systematic biopsies came out, radiologists were doing them, but after that urologists learned to do it by themselves, they took over the standard prostate biopsies for years. I mean, many years majority of the urologists were doing the standard biopsies by themselves. But with this new technique, cognitive fusion biopsy is not suitable for the urologists. You need to know very good. You need to have a very good MRI knowledge, and to be an prostate MRI specialist, even for a standard radiologist, you need to have at least like 100 or 150 prostate MRIs in training. I mean, for my fellows, I say that at least you need to see at least 100 prostate MRIs with me, so you can now report them by yourself or analyze them by yourself. Some authors say that cognitive biopsy, cognitive fusion has a difficulty in targeting small lesions, but if you do saturation biopsy to those small lesions, saturation technique, you can also diagnose them easily. Difficulty in targeting anterior or apical lesions. It is also, debate on this, because in experienced hands, we can do even anterior lesions, we can do apical lesions without any problem. I will show a few images of my patients from Baku, because I started doing prostate biopsies and cognitive fusion biopsies and MRIs before in Turkey. But for the last 5 years, I've been practicing in Baku. So this is a 61-year-old asymptomatic male patient with a slightly elevated PSA. It was found out in checkup. Okay, so after this PSA, we decided to do an MRI with the 3 Tesla device, and we see here on right mid posterior part of the right peripheral zone, we have a very dark lesion, very small also. It is like less than 1 centimeter. On the diffusion MRI, it is bright, and we verify this brightness with the ADC. It is very hypo, so it is diffusion restriction. It is definitely PIRAS 5 lesion. So this is how I mark my lesions on the cognitive biopsy before the biopsy. It may be probably, let me see. Yeah, it's not a video, it's an image. So this is my setup for the fusion biopsy. We have like 12 12 specimens for standard systematic biopsies, and we have at least 2 to 3 extra specimens for the fusion, for the lesions that we see. In this patient, we have only 1 lesion to biopsy, so this one will not be used. We will fill only 13, 12 plus 1 from the lesion. And we do these biopsies in the operating room under the sedation because it is a millimetric procedure. I don't want patient to move. And also, I think professionally, doing a transrectal biopsy or even a transperineal, it doesn't matter which approach you use, transrectal or transperineal, you need to be sure that your patient will not have any psychological trauma also, okay? So I recommend my patients to do all procedures under sedation. When you can do it with local anesthesia, but I prefer sedation for the psychological effect also. This is the video. The lesion was here. Okay, it was here on the right part. Now you'll see the needle going through this lesion, and this is the cognitive fusion biopsy. Okay, so when I send this specimen to the pathology lab, I always define the PSA, the MRI result of the patient, and what kind of biopsy that I took. 12 core biopsy from the systematic parts and 1 from the lesion. And I exactly define where the lesion is located in the on the specimen. So this is the result of that patient. Pay your attention for this result, please, because in this image you may see that all other systematic cores were benign. Benign prostate, benign prostate, benign. All other cores were benign. And the 13 specimen that we took from the lesion is a Gleason score 8. It's pretty important, high value Gleason value carcinoma that we have diagnosed in this patient. So this patient, if he had not gone under the MRI and we didn't do a target biopsy to this patient, this biopsy result will be benign. So we will miss this tumor in this patient if we didn't do MRI and target biopsy, fusion biopsy to this patient. So this was a simple example of the cognitive fusion biopsy that we do daily in our practice. So how do other devices work? They have really different navigational techniques. I will not go deep into this navigation techniques. Different brands, very expensive devices. I have used at least 2 different brands. They are pretty expensive. They have different navigational techniques. One has a navigation by organ. The other has sensors for navigation. Some has elastic fusion capacity. Some has rigid fusion capacity. So it is very hard. One, you have a robotic arm, doesn't have a robotic arm. So it is really hard to choose which one is good, which one is best for you. And the industry is manipulating the doctors easily on these devices. But for nowadays, if someone is planning to do a fusion biopsy with the device, I would definitely recommend to choose a device that has a capacity to do this biopsy transperineally, because transperineal route is much less risky from the perspective of sepsis for the patients. And we can do target focal therapies, which I will talk later, transperineally. So this was our first guideline for the fusion biopsies and multiparametric MRI in our university hospital in Istanbul that we have prepared when I was a resident. This is also images from our old years with the device navigations. It's very tough to find the lesion here, to mark it, then the device should accept it. It takes a really long time, and for the navigation also under the ultrasound to those lesions, it takes a really hard time, more time to find out a lesion in these devices. It's scanning it. You have to wait. When it starts, it shows you where the lesion is on the ultrasound. Now it fuses the MRI with the ultrasound image. But for experienced radiologists, it is really, I know where is it, so I just put a needle there and stick the needle and take my biopsy from there. These devices are more suitable for the urologists who want to do these fusion biopsies, but still, without a diagnostic radiologist by your side who will help you to find those images on the MRI, you will still have problems. You will still miss some lesions. Okay, so even if you want to use a device for the target biopsy, for the fusion biopsy, you need to co-work with the experienced prostate radiologist. So, what does the academic data show us? This is from the 2017 first comparison between cognitive biopsy and the device biopsy studies. Okay, so these first studies showed us almost no difference with the clinically significant, with catching the clinically significant tumors on both techniques, cognitive or device. Okay, in experienced centers, finding out, diagnosing clinically significant tumors was same with device or the cognitive technique. And also, when we talk about the techniques that these devices use for the fusion, device fusions, we have sometimes even have errors that they were making in early years. Nowadays, I'm not sure about how they work because for the last 5 years, I have not been using any device. I am doing my all fusion biopsies cognitively. Sometimes I use software, some softwares which are just giving me fancy videos to use, to share. Okay. This is also a video from other device that I have used in previous years. You need to, it really takes a long time. You need to select the margins of the prostate gland in every slice of the MRI image. It's really annoying for me, to be honest. Then I mark the lesion here on the MRI. So then they make a three-dimensional analysis of this image, MRI image. The device remembers the place of the lesion, which I spotted there. And then they transfer this data to ultrasound device where it shows me the places where should I put my needles to do fusion biopsy. You see how much time it takes? I don't find this technique user-friendly, at least from my perspective. Okay, the advantage of cognitive fusion, actually advantage over the cognitive fusion. They say that cognitive fusion, you find you target small lesions hardly. It's because that's why they say that some authors claim that they were claiming actually in early years. It's a study from 2012. They were claiming that the cognitive fusion is not good for small lesions. You may miss them. Those years they were right, but with the years of experience, the experienced radiologist can target even the 5-6 millimeter lesions easily. But for the lesions that are smaller than 1 centimeter, I always do saturation biopsy for that part of the prostate. I do at least take 6-7 cores from the area that I spotted in mind cognitively. And also advantage of these devices, they have an ability to record the biopsy that was taken. So you may record and save the data of imaging that you took from the right place. Actually, I do the same with my cognitive technique. In every time when I do cognitively, I save the videos from which part I took the biopsy on my ultrasound device. So I can you can also save the data and record your biopsy data videos in cognitive biopsy also. So this is also one of my recent patients. I want to show you an image from the 1.5 Tesla MRI. So in the beginning of my presentation, I told you that 3 Tesla is almost always preferred, but nowadays, new generation 1.5 Tesla devices are also good if you have a good applicator from the company, and with that applicator, you may improve your quality of your image on the 1.5 Tesla MRI, which will bring you close image quality to the 3 Tesla. This is a 62-year-old male patient with 11 PSA. He came to me 1 month ago. He had also some symptoms of dysuria. I prescribed him antibiotics, and after 1 month with the urologist, we checked his PSA again. It was elevated. It came to 11, so we decided to do MRI. Now in the MRI, we see a different lesion. It's not a peripheral zone lesion. We see the lesion in the transitional zone of the prostate, very close to the bladder. It is axial plane T2 image. It is coronal plane T2 image. Here bladder is anteriorly. Here bladder is superiorly, and also sagittal image. So we see the lesion very close to the bladder. It's pretty dark on the T2 image. This is also T2. This is our diffusion and restriction brightness here, and we double check it with the ADC mapping. It is hypo on the ADC, so it is typical Pirates 5 lesion for the transitional zone of the prostate, because you know that majority of prostate cancers are seen in peripheral zone, but sometimes also we see them on transitional zone. This is a biopsy procedure of this patient. This is my MRI on my laptop. This is my ultrasound device. So I do cognitive fusion, and I find this lesion here on ultrasound. This is my software that sometimes help me to put a marks for this lesion. This is a biopsy procedure. You see, it's anterior lesion. It is close to the basal part of the prostate, and we can easily put a needle on the anterior parts of the prostate also during the cognitive fusion technique. And here also very interesting results of this patient. You see all other standard cores, like from 1 to 12, all of them are benign. All of them are benign. Only this 13, which I took from the Pirates 5 lesion, is Gleason 6 3.3 lesion. Okay. This patient also had one Pirates 3 lesion from the left. From the right transitional zone. I took a biopsy from that lesion also. It was also benign, but our Pirates 5 13th specimen is a cancer. Okay, so if we have done standard biopsy only to this patient, we will miss this tumor. Okay. I will shortly explain you the inboard biopsy, which is done inside the MRI device. uh, it is good. It shows us very nice results, but you can't do 12 systematic biopsies under the MRI device there. It is really uncomfortable. And you see how uncomfortable it is. Like, this is the MRI device, this is the patient, this is doctor there, this is the huge transrectal probe that we put inside there, inside the MRI. It is really uncomfortable. It has some advantage, but I'm not going through this detail, okay? Cognitive fusion is really faster than it is. More comfortable for the patient. Device, I mean, this is the device fusion over the MR inboard, but I mean, I'm going through this fastly, okay? These parts. Okay, so what do we have here? Excuse me, I have something popped up for my, okay, here. Okay. Why don't we do only target biopsies? Why I still do systematic biopsies also for my patients? I mean, systematic plus a fusion biopsy. Short answer, it's because the guidelines say so. European Society of Urologists, European Urological Association guideline still recommends us to still do the MRI to do systematic biopsy for possibility of MRI negative cancers. Okay. Excuse me. Okay. So for the this is also for as an example answer to my previous question, why we still do systematic biopsies, combination of the systematic plus the studies that made a that evaluated difference between if you do standard biopsy at those years, because MRI imagings were improved in years, but at those years, not everybody was doing standard MRI techniques. So some may have missed the lesions. But today in 2026, why I still do, it's because the guideline hasn't changed yet. But if I had my own personal approach, I would not use systematic biopsies any longer. This is from the guideline of urologists that says us that for the Pirates 3 lesions also there is a strong evidence when MRI is positive. You need to combine these two techniques. So I will not go deeply to these comparisons between the MRI device cognitive fusion, but I will just show you the results of very important meta-analysis and systematic reviews that compared us, because in 20 controlled studies actually did not show us the superiority of these devices to make a fusion. Okay, so software fusions seems to have a little increased benefit compared with cognitive fusion. They said in early studies, these were from the early studies, but the most important thing for us was the result of this 2017 meta-analysis, okay? This systematic review that took 43 studies comparing the cognitive fusion with a device fusion, okay? So before 2017, I was not doing cognitive biopsy. I was doing like 1 to times a month a biopsy with these devices, because we were not sure that if a cognitive biopsy is as good as these devices, okay? Because very previous publications, some were saying cognitive biopsy is good enough, some were saying, it's inferior to the devices, but this meta-analysis showed us that when we do comparison between device fusion, cognitive fusion, and MRI inboard, inside the MRI techniques, three techniques were compared with this meta-analysis, and it showed us that there was no significant difference in diagnosing clinically significant cancer. That's why starting from 2017, I started doing cognitive fusion routinely, because it is fast, it is very cheap, and it is very comfortable for me and my patients. So this is clinically significant cancer diagnosis. You see, 34, 33, 30, no statistical difference in catching the. This is the future trial, actually. This is the first big randomized controlled trial also after the meta-analysis. It also verified the results of the previous meta-analysis. The future trial also showed us that these techniques are totally equivalent in catching the clinically significant cancers. So this future trial was very important. These slides are actually very old. I mean, I have been using these slides for years. General information. So the result about fusion biopsies is MRI brought a real big paradigm shift in the diagnosis of the prostate cancer. Thanks to MRI, we have now a chance to do target biopsies, and patients with PIRATS 3 or over 3 should be done with fusion biopsy. Actually, PIRATS 3 is debatable. Some authors say that you need to do PIRATS 3 biopsies. I actually, when I evaluate my patients with their MRI images, some PIRATS 3s I prefer to do. Some PIRATS 3s I prefer not to do biopsy. That's why it depends on the clinical findings, the history of the patient, and so on. Okay. So now I want to move on with the focal treatments, but now I want to make a small pause and ask if you have any questions for this part. Kasiyet, hello, Dr. Kasiyet?
Yes.
Are you there? Okay. Are there any questions? Because I want to give a little pause. If there are questions from about MRI and the fusion biopsy, before I will proceed with the focal treatments, I can get questions about MRI and the fusion biopsy.
Если будут вопросы, я думаю, они напишут.
Okay.
Сейчас
So you want me to move on? Okay. Okay. Let's move on with the focal treatments. So now I will give you a brief information about focal treatments of the prostate cancer and the current status of these focal treatments in the clinical practice. Okay. So we have to look at the prostate gland as a very useful organ, just like any other organ in our body. Okay, so we don't remove whole liver when we have a liver cancer. We don't remove whole kidney when we have a kidney cancer. I mean, we do not prefer to do it nowadays. Because in history it was totally different, right, for other organs. But the first idea that we can spare some parts of the prostate when we treat prostate cancer came to our academy with the Dr. Gary Onick. Okay, when he first introduced nerve sparing cryosurgery technique in 2002. It was really all time. I was a first grade medical student that year. He was a radiologist, interventional radiologist from the Florida, and he called it male lumpectomy in the next years. In 2008, when I was a graduate from the medical school. And he published his 2-year follow-up of his cryoablation data patients. Okay, you see, in last years, a number of publications about focal treatments of the prostate cancer are rising very fast. This is from 2022. Okay, these years. You see how much publications, how many publications we see in last years about focal treatments of the prostate cancer. So today we have ability to localize the prostate cancer. Now we can see how big it is inside the tissue, prostate gland, how where it is exactly located, and we can even see its invasions to other adjunct structures. We can see it on MRI, we can verify it with fusion biopsy, and we can do PSMA PET scans, either it's PET CT or PET MRI. This is for an example of PET MRI image that we have been using in Istanbul. This is a PET MRI. This is MRI T2 image, and we show here different lesions from the different zones of the left peripheral, right peripheral, right transitional, central located lesion, and each of them have different uptakes of the PSMA. This is an example of the multifocal cancer. So multifocal disease is not an absolute obstacle for the focal treatment. When we see an multifocal disease, it is not always still necessary to do total prostatectomy. We need to first understand the localization and the biology of the tumor first. The clinical behavior also of these tumors differ, as you know from our daily practice. So these are for now what radical treatments we have in our hands with the local prostate cancer, which is not metastasized. We have either a radical surgery or we have a radical radiotherapy. Okay, so in both we see here is a classification, the table of the side effects of this both and complications of these both treatments. You see in radical surgery, still we have a high side effects. Even if you do it robotic prostatectomy, we still see impotence, incontinence, and other urinary and sexual impairments in the patients, especially in the young patients. Now we have an ability, we have enough data to compare these complications and these side effects with the results of the focal therapies. Okay, so we see that in the focal therapies we have much less urinary issues, we have much less incontinence and impotence. So how we should select patients for the focal treatment. The data that we have for now is is like men with clinically significant prostate cancer are choosing the quality of life over the length of life. So for a male, even for elderly males, the quality of life and their sexual capacity is pretty important. We cannot avoid these concerns of these patients. And 1/3 of patients who undergo radical prostatectomy, they regret the results. They regret their decision to have undergone the radical surgery. So that's why we start to look for alternatives, okay? And when we look into the history, we see this Bernard Fisher as an idol, as an mentor for all doctors who are dealing with cancer, okay? Because he, as a breast surgeon in the 70s and 80s, he was giving a big fight and big debates against conservative academy of the breast surgeons at those years, and who were accusing him that the lumpectomy that is today is our standard was a murder from their perspective of view in those years, and they were accusing Bernard Fisher with malpractice and a murder. But what he had told to those conservative surgeons at those years is very nice sentence. He said that in God you may trust, but all others should bring data. So he brought his data about lumpectomy to the conferences when he presented his data comparing lumpectomy with the radical mastectomy in those years. Now we have he made a huge paradigm shift in the surgical management of the breast cancer, and he changed totally the philosophy of our philosophy to approaching a cancer disease. That okay, it is a systemic disease from certain point, but before that point, it is a local disease, and you may do just a locally conservative treatments without doing radical surgeries. Now we use this philosophy in almost all cancer types, like in breast, in kidney, in thyroid. Now we do, as an interventional oncologist, I am doing ablation for the micropapillary carcinoma for thyroid. Without any radical thyroidectomy. So patients don't need to lifelong use thyroxine. Also in lung cancer, we do like wedge resections with surgeons, we do ablations, same as with the liver and the colon also, okay? So, but which group of patients are good for focal treatments? We have three approaches in management of the prostate cancer clinically. We have either active surgery for the low radical treatments, and we have focal treatments, right? So we have to find the patients which are good for the focal treatments. So we classify them as risk groups also, which are the low risk group, intermediate and high risk groups. So this will help us to classify which patients will benefit most from the focal treatments, okay? Many of the focal treatment studies today are coming from the Great Britain, from England mostly, and they have a nice criteria for the focal treatments there. To be honest, I am not practicing focal treatments here in Baku because I don't have the HIFU device here. I do HIFU in Turkey. HIFU is the high intensity focused ultrasound device. It is totally non-invasive with the outside ultrasound beams. We ablate the prostate, but I used a laser ablation and the radio frequency ablation in the first years when I started doing focal treatments. But for now, HIFU seems to be probably the easiest for me to use. But the transperineal approach will help us to use other techniques also. How many prostate cancer patients can be focal treatment candidates? So also this Imperial College in London and NHS, National Health System in Great Britain, they have their nice studies about this selecting the patients. They have the picture study, rapid cohort, and several other programs. I'm not going through the detail. The focal treatments are there in the randomized controlled trials? Yes. They have concluded also this English, our colleagues have concluded their studies. Also a study from Atlanta and Kronos A design. There are some ongoing studies going for now. But we have a multi-center study of 5-year outcomes of focal therapy, also from Great Britain, showed us the results of the HIFU at 5-year results. You see, excuse me. So these are showing us the overall survivals of 5-year from different risk groups to 5-year survivals. Okay. And they are pretty good, pretty nice results. Even we have 8-year results published, I think it was 2020 or 21, I don't exactly remember. They had published their 8-year results, and it's still very promising. But which group? Low to intermediate risk patients. Okay, we do not prefer to treat focally high risk patients. Okay. So what are the focal treatment techniques? HIFU, cryoablation, laser, electroporation, which we call is nanoknife. It is also very effective, but it's very, very expensive. Radiofrequency ablation with bipolar ablation, microwave, and others so on. So the ones that we use in our practice is the HIFU, cryo. Some of my colleagues love cryo. I have not access to cryo. If I had the cryo, I would prefer cryo over the HIFU. Cryoablation, HIFU, laser, which we used in the early years. Now we don't prefer using a laser. It is also very effective. Frequency and a microwave are too aggressive for the prostate gland for now. So cryo and HIFU are the emerging and most used ones. Okay, this is from our HIFU patients from early years. This is a right peripheral zone lesion. On T2, it's hypo diffusion restriction here. It is typical. It was diagnosed as Gleason score 6 tumor. We have ablated that zone with the HIFU. So after the ablation, we see the necrosis in that area. It is on T2. It's bright now. You see, it was dark. It was tumor on T2. Now it is a cystic lesion, necrotic site part, necrotic cavity of that tumor, previously tumor lesion. So it is totally cystic and necrotic, no relapse or no, we haven't seen any tumor in this patient later on. Yeah, this is that patient. He had the Gleason score 6. Also another patient. This is from also our early years. This is a T2 diffusion restriction. It's on the left peripheral zone. It was Pirates 4 lesion. We ablated a larger zone here. This is T1 contrast enhanced image. It is totally necrotic here. This is a patient this is my colleague's patient. He had done it with the nanoknife. It is electroporation technique. It is also left side peripheral zone lesion. Close to capsule. It is also at invasion to the transitional zone. This is the catheter inside the urethra to make it safe. And this is area of necrosis after the electroporation. So, are there any complications? Yes, there are, but not as much as the other radical therapies. Urinary tract infections we see orchitis, epidermorchitis. Recto-urethral fistula was seen in the early years with HIFU, also with this electroporation maybe, but with the HIFU experience, we see less and less that's recto-urethral fistula complication. I haven't seen for my in my patients. Endoscopic procedures like extra urethral, extra procedures for urethra or rectal fistulas. I mean, they are really, very, very low rate of complications. What is needed for a successful prostate-focal treatment program? You definitely need a multidisciplinary approach. I have not been doing these treatments or even the fusion biopsies, decision of the fusion biopsies without my urologist friends, okay? We are approaching to all our patients multidisciplinarily because all kinds of cancers should be approached with the multidisciplinary tumor boards for all kinds of tumors. So my philosophy as an interventional oncologist is to evaluate all patients multidisciplinarily because every day I have different tumor boards. One day with urologists, one day with gynecologists, one day with hepatobiliary surgeons. So my all days are going with the tumor boards for different kinds of tumors. And for the prostate cancer, we also have a teamwork with urologists. So here I want to stop and I may see if you have questions, okay? These are all examples and last data. So we are really hoping that and thinking that these focal treatments will be a standard of care in coming 10 years, okay? Because it is the prostate gland is not a useless gland, okay? And we diagnose prostate cancer in very early stages. Now with MRI and fusion biopsies. So with the low Gleason score tumors, young patients who do not accept active surveillance, we need to have something to offer to those patients, okay? Low Gleason score, young age, I mean the 50s, 60s, in their 50s and 60s. These patients don't want the risks of the radical prostatectomy. They want to preserve their sexual functions and they want to be sure that their sexual functions will be preserved after the treatment, and they don't want active surveillance. So we need to have something in our treatment options to offer them. So that's why focal treatments, especially HIFU and the cryoablation, will be a part of the standard of care in coming very soon future. Thank you for your attention, colleagues.
Thank you very much. Спасибо большое за интересный доклад. Здесь у нас вопрос. Написали: добрый день, спасибо за прекрасный и познавательный доклад. Мой вопрос: как вы действуете при отрицательной биопсии и сохраняющемся повышенном ПСА?
Okay. Это false negative results of the fusion biopsy. Если fusion-биопсия была сделана из правильного места, где мы на МРТ видим какое-то там образование, так скажем, да, и мы сделали правильную биопсию, и результат нам показывает, либо это аденома, либо это какая-то часть простатита. Если там, то есть, если биопсия нам показывает какую-то патологию там, либо это может быть доброкачественная какая-то опухоль, как аденома, или же это может быть фокальный простатит, то, конечно, мы с урологом делаем лечение. Потом мы делаем close follow-up, очень strict follow-up. Раз в 3 недели проверяем ПСА. Если он продолжает увеличиваться, то повторяем МРТ. Иногда, если пациент первый раз подошел ко мне с готовым результатом МРТ из другого центра, например, ему сделали МРТ 1,5 Тесла, да, то приходится повторять уже МРТ, у нас 3 теста на МРТ. И иногда, если мы на повторном МРТ опять же видим там какую-то опухоль, да, и какое-то образование, которое там ПИРАЦ-4 или ПИРАЦ-5, то повторная биопсия происходит, конечно, обязательно.
Понятно.
Но если там у него простатит был, например, да, или же там у него аденома, то лечение уролога там либо антибиотики, либо альфа-блокеры, либо другие, которые лечение уролог выписывает пациенту. После лечения мы продолжаем следить с результатами ПСА, и если опять он не снижается или продолжает повышаться, повторное МРТ, конечно.
И у меня сейчас такой вопрос возник. Например, при трехтесловом аппарате мы знаем, что есть дополнительная, ну, не дополнительная функция, а как бы выполнять спектроскопию.
Да.
И я также читала научные статьи, где его в практической диагностике не используют, но в основном используют при написании научных статей. Пробовали ли вы делать спектроскопию на образование предстательной железы?
Это были очень сложные. В начале презентации я вам показал мои первые слайды из 2012 года, да. Вот в те годы, когда вот я был в Дубровнике, вот в этом, когда писали этот гайдлайн в 2012 году, European Society of Urogenital Radiology, вот в этом гайдлайне был опубликован ПИРАЦ версия 1, ПИРАЦ. В этом ПИРАЦ версия 1 спектроскопия была must. То есть мы все, каждому пациенту делали тогда спектроскопию. Но потом мы поняли, что спектроскопия, конечно, спектроскопия очень интересная техника, но она тоже занимает очень много времени на ежедневной практике делать спектроскопию каждому пациенту, это почти на наши дни уже невозможно. И дата, которую мы получаем от спектроскопии, она не сильно изменяла наше решение, какой стадии пирации мы пишем пациенту. Понимаете? Поэтому в версии 2 уже, второй версии пираться, мы уже избавились от спектроскопии, чтобы стандартный МРТ, не важно делать спектроскопию. Но спектроскопия нам давала интересные данные о молекулярной состоянии опухолей, да? Но на данный момент наши дни, как исследования на спектроскопии тоже уже остались позади. Но мы в те годы, да, очень много делали спектроскопии.
Понятно. Коллеги, есть ли у вас еще вопросы? Если есть, вы можете задать или также написать в чат.
Я вижу, нет, да? Извините, сколько у нас сейчас подключенных?
Сейчас уже осталось 10.
Окей.
10, да.
Наверное, все резиденты, да, онкологии в основном. Ну, если бы были бы урологи, наверное, они задали бы какой-то вопрос. Урологов нет, понимаю.
Мы всем отправили.
Окей.
Но также запись экрана мы также им отправим.
Окей.
Все, спасибо большое за интересный
Не за
доклад.
что.
Это было
Не за
очень
что.
интересно.
Спасибо
Ам,
за приглашение.
Да, спасибо вам большое. А вы на съезде будете? Можно ли спросить у вас?
Самарканд, да?
Нет, в Казахстане, который пройдет.
В Казахстане нет. Вроде у меня приглашения не было, насколько я помню. У меня, честно говоря, каждый месяц по два конференции бывает, но я успеваю только наши местные, потому что здесь с студентами я чувствую, что стараюсь больше быть вместе с студентами, да, потому что они имеют очень хороший кругозор на будущее, да, у них хороший вижен, потому что в наших странах СНГ я здесь не жил в Баку почти до 35 лет. Вот. Старых консервативных врачей менять сложно. Лучше тратить время на молодых.
Да, это правильно. Хорошо. Спасибо вам большое тогда. До
Окей. Я
свидания.
буду на Самарканде, не знаю, вот следующий апрель в Самарканде онкологическая
Да,
будет конференция
в апреле сказали.
туркоязычных стран, да, вторая конференция. Там у меня будет презентация на нашу практику локальных лечений гепатоцеллярной карциномы. Хорошо?
Угу. Все,
Может, там
хорошо,
увидимся
понял.
с вами. До
Да.
встречи, до свидания.
До свидания.